TRT group. Hey, this is Justin, and today I'm doing the first installment in a series, and the series is called The Symptoms of Hashimoto's. So today I want to talk about the gastrointestinal and the neurological manifestations of Hashimoto's. So without further ado, the first subject we'll talk about are the GI, the gastrointestinal manifestations of Hashimoto's. Most common gastrointestinal symptom that patients with hypothyroidism complain of is constipation. And this is due to a decrease in gastric motility. In other words, it slows down how fast stuff goes through your gut, to put it simply. Furthermore, having decreased gastric motility, what that does is it leads to bacteria becoming stagnant in certain areas. This can lead to overpopulations and disproportionate growth of bacteria in your gut. Well, that condition itself is called SIBO, or small intestinal bacterial overgrowth. And that occurs because there's nothing moving it along. Instead, it's just kind of hanging out, pulling, and starting to become stagnant and overgrow. Also, patients that have Hashimoto's are actually 4 times more likely to have celiac disease. Now, to diagnose celiac disease, the gold standard is the endoscopy with biopsy. There are a few blood tests you can do to kind of roll it in as well. Obviously, they're not the gold standard, but they're pretty decent tests. There's the endomysial antibody test, there's the deaminated gliadin antibody test, and there is the tissue transglutaminase blood test. Oh, and yes, they're all 3 blood tests. Another gastrointestinal manifestation or complication that can occur from Hashimoto's is pernicious anemia. And about 10-ish% of patients with Hashimoto's develops pernicious anemia. And this is speculated to be secondary to the atrophy of parietal cells. Now, if you don't know, parietal cells are cells in the stomach that secretes gastric acids. So thus, the parietal cells secrete the acids that help you break down and absorb your food. Hashimoto's could possibly result in the production of anti-parietal cell antibodies. In other words, Hashimoto's could lead to developing antibodies towards those parietal cells that secrete the acids necessary for absorbing your food. This can lead to pernicious anemia. Pernicious anemia is primarily characterized more by B12 and or folate deficiencies. So the next area I want to talk about are the neurologic and or neuropsychiatric manifestations of Hashimoto's. So just like low testosterone can cause cognitive dysfunction, or what we commonly refer to as brain fog, so can hypothyroidism. In severe, really end-stage, terminal, severe type cases that we never clinically see, a condition called myxedema madness can actually occur. And that's where the patient actually experiences severe confusion, severe disorientation, and even to a certain degree, psychosis. But again, those are not cases that we see in clinical practice. Now, from a neuropsychiatric standpoint, one of the most common symptoms or manifestations of Hashimoto's would be depression. And that depression may or may not be accompanied with poor or reduced executive functioning. In terms of common physical findings on the physical exam in patients with hypothyroidism, diminished deep tendon reflexes are often present, depending on the severity of the case. Deep tendon reflexes, or DTRs for short, that's essentially when your provider takes a little reflex hammer, boop, and taps you on the knee or taps you on the thumb or whatever. They're measuring to see if you actually have that good reflex, because in overt severe cases of hypothyroidism, it may be delayed or diminished. So thus, that's why we do it. Another not fully understood manifestation of hypothyroidism are muscle weakness and muscle pain, and particularly it tends to involve the proximal areas, primarily the shoulders and the hips. And we don't fully know why it's caused by it, but it's speculated to be secondary to 2 different reasons. One is creatine kinase. The clearance of it out of your body is decreased in hypothyroidism. And 2, there's also diminished oxidative capacity and oxidative metabolism of the mitochondria in the cells. So between the 2, it's got a compounded effect. Now, some literature even shows that creatine kinase enzyme levels may be elevated for years prior to a patient developing overt Hashimoto's. And lastly, today I will talk about some of the hematologic findings that may be present. So many patients with hypothyroidism will present with what we refer to as macrocytosis. So that's when their mean corpuscular volume is elevated, or their MCV, which you would find on their H&H. There's actually been several times that I've actually seen an elevated MCV in the context of a normal H&H months before the hypothyroidism was actually overtly presented. If you see this aberrancy, but you don't see hypothyroidism, just keep in the back of your mind that it may be developing, maybe kind of flying under the radar, just as an FYI. So roughly about 10%-ish of hypothyroid or Hashimoto's patients will develop pernicious anemia, as evidenced by the elevated MCV. That's secondary to decreased B12 and or folic acid absorption. Also, hypothyroidism can decrease the production of EPO, which is responsible for stimulating the production of red blood cells from bone marrow. Another hematologic abnormality that is somewhat common, and I tend to see this more in women than men, is easy bruising. And this is due because hypothyroidism can induce a hypocoagulable state. In other words, it reduces the coagulation ability of your blood. And thanks for tuning in today, and keep your eyes open for the next installment of this series. Thanks.